Hello, everyone, and thank you for joining today's UMB Institute for Clinical and Translational Research Enrichment Series presentation. Before we begin, I would like to start off by reminding everyone that this event is recorded. Recordings of all ICTR Enrichment Series events are posted on the ICTR website. We will reserve the last 10 to 15 minutes or so for questions. It is helpful for us if you add your questions in the Zoom Q&A feature at the bottom of your screen as they come to mind. As you leave this Zoom session, you will be redirected to a survey. We welcome your thoughts on how we can improve our presentations and what additional topics you're interested in. And now I would like to introduce you to our special guest speaker, Dr. Daniel Ford. Dr. Ford is the director of the Johns Hopkins Institute for Clinical and Translational Research, our sister ICTR, as well as the Johns Hopkins University Vice Dean for Clinical Investigation. Dr. Ford is also the PI, along with Dr. Stephen Davis, of the recently awarded NIH NCATS Clinical Translational Science Award, the CTSA. Dr. Ford will describe the current environment for investigator-initiated clinical trials and how to work with the CTSA Trial Innovation Network and the National Patient-Centered Clinical Research Network, PCORNet. Dr. Davis?
I hope everyone can hear us. There was just a message in the chat, and now it's good. Okay, so yeah, it's an absolute pleasure and delight to introduce Dan Ford. Dan is an international and national expert on the clinical trials, and he really is the go-to individual if anyone in this country or around the world wants some really good advice how to do a fantastic clinical trial that is going to have impact and improve the health of that particular community and nation. And I'm not going to tell you how long he's been doing this, but he has got a wonderful CV, and he's made a tremendous impact at our national level, both at the CTSA and clinical medicine. So thank you, Dan. Looking forward
Great.
to your words.
Good. Well, very happy to have been given the opportunity to come and talk to you a little bit about, how we can help you do multi-center investigator-initiated clinical trials. That's really what we're talking about here today. And we understand that it isn't easy. And I think the NIH has understood this as well, and why federal agencies have created some approaches to make it a little bit easier to get these trials both, planned for, funded, and conducted on time. So, what is the current environment for multi-center clinical trials? Funders seem quite committed to the multi-center process, right? They believe they have greater impact than single-site trials. They think that they accelerate recruitment, so you can get a trial done more quickly. All of those are probably true. For example, if you take that first statement, PCORI has said they're not going to fund any comparative effectiveness research projects that are not national in scope with multiple centers. So they've made it even more explicit in some ways than the NIH has done. So despite everyone thinking that these trials have more impact and, and are the preferred approach to single or even, two-site trials, multi-center randomized clinical trials, they're expensive and heavily scrutinized. So that, when you're talking about 10, 15, 20, $30 million, the ability to get them funded and the amount of time it takes to go through the various review processes are something that we have to just recognize. And we think that the NIH is even more hesitant or conservative of what they fund for multi-center clinical trials right now, and that everyone needs to be prepared to do that. At least 75% of large randomized clinical trials are now multi-center. And even that, there's, as you can imagine, there's some questions about really what is even the definition of multi-center. Like at Johns Hopkins, if we're doing a trial that includes Bayview Medical Center and Johns Hopkins Hospital, is that multi-center or not? In some ways, yes, it may have two different research teams, but it depends. Nonetheless, this is where it's going. And even the patient oriented, groups like the American Heart Association or the Multiple Myeloma Association, whatever, they very much push multi-center trials as well. At the same time, we do have to recognize the burden for the investigator and the research team is substantially higher. You've got to deal with much more complex budgets in terms of, the site budgets that you see. There's a whole nother layer of communication that is required in a multi-center trial, and how you may deal with, the different steering committees or the data committee or the publication committee, and how you just operationalize the day-to-day. We'll talk a little bit about even the single IRB process, which was invented supposedly to improve efficiency, and maybe it does at some level, like in the multiple years of a clinical trial where it's easier to change protocols that way. But in the beginning, the setup for a single IRB studies is probably not easier. And, we could talk about different approaches at the end, if you like. So I'm going to talk to you about two groups that I'm involved with that are both have both created networks of sites, institutions, academic centers, that one of their main goals is to promote multi-center clinical trials. So I'm going to talk to you first about PCORNet, which is the clinical research network that is funded by PCORI, the Patient-Centered Outcome Research Institute. And then I'm going to switch over to talk about the Trial Innovation Network, which is the NIH-funded consortium activity amongst the 60 CTSA institutions to improve clinical trial performance. So first, let's look at PCORNet. And PCORNet is slightly different because PCORNet has both a data component and the ability to do clinical trials. So as you see here within PCORNet, we obviously start with the providers and researchers. There is access to EHR claims and patient-reported data. So we have developed what's called the common data model, and we all know there's a few too many of these EMR-based models out there, but that is the one that is used in this network. It is a federated system, which means none of the data leaves the home institution, but the queries come out from the coordinating center and get to the academic centers, and then the counts of the data is provided, and that's the most common approach to see this. And I think you look as PCORI's priorities on the clinical trial side. It's important to see that comparative effectiveness research, which is really the sweet spot for PCORI right at the moment, which means they want to fund studies where there are two options for patients, both with some evidence to back up their use, either through guidelines or common use, and comparing two options to see what seems to be the best outcome for patients. So just a few data insights via PecorNet. So um, the one kind of unique component, if you're dealing with PecorNet, that you want to try to understand is, as you see, each one of these dots is a site. There are multiple sites, um, but they're organized into CRNs, or clinical research networks. So if you see that one in the Mid-Atlantic with the P, PATH, that is the clinical research network that Johns Hopkins is a part of. Um, and, sometimes they don't make total sense in terms of how they were created. Initially, it was clearly Mid-Atlantic. So it was Pittsburgh, Johns Hopkins, Temple, and Penn State. And then, because we're on the fourth iteration of this that we expect to start in January, there's been some changes. PCORI is a little bit more proactive about moving the sites around to create networks. So when one of the Midwest clinical research networks was not funded, they asked us to bring in Ohio State and University of Michigan. So they entered into our network. And then most recently and they brought us, they asked us to add Geisinger Health System. And then in the latest iteration, in an attempt to create a more diverse patient data system, we also added Rush in Chicago and Boston University in Boston. So if you see that, that's the PATH network, and you could look through all these others that would be, somewhat similar. The reason, and so the coordinating center for PATH is actually University of Pittsburgh. So that if you want to deal with PCORNet, they're going to want you to deal with more than one clinical research network. And we can guide you through that process. But I do want to point out it, because in the Trial Innovation Network, it goes directly from the TIN to the institution. And in PCORNet, it goes through these clinical research networks. And this just gives you an idea about, the national coverage. You can see that there is a substantial group in the Mid-Atlantic states. California was kind of a little bit of a lost state for a while until they added in some additional sites there to really help with national representation. And if you look at the common data model, you can see where it's on the ready for research side: demographics, diagnoses, procedures, vital signs. You see the usual, and then they have available but still evolving, and that's a pretty accurate approach, where you can't assume that every academic center, for example, is including tumor registry data to the common data model. It's growing, it's improving, but there you may not be able to get the data from all of the sites in the PCORNet system. Community engagement via PCORNet is certainly part of it. As you may know, this has been a priority for PCORI for some time. And what do we broadly mean by communities? Patients and caregivers, clinicians and clinical staff, insurance, policymakers, others. All of them we consider to be communities that you need to work with to develop the best, most impactful study. And I think you see some of these steps. I know Dan Mullins at your institution has done a lot on trying to understand this process of how communities can work effectively for studies and clinical trials. And I think you see all of these steps along the way that are important to have the type of study that you want. I'm showing this. I was thinking about whether I should take it out, because this puts PCORNet on top, and frankly is a bit of an advertisement for PCORNet. I think some people in these other networks would not really accept these box designations quite as in the same way that PCORNet did. But I think it points out that we know there are other data networks out there. ENACT is the one within the CTSA, but probably reflects about 20 institutions. Trinetics, which I know is growing at University of Maryland, is another approach to look at it. We talk about in PCORNet this easier connection to patients and providers when the data comes in. So if somebody has some question about the data, we have a process where it's easier to get back to a clinician or a service provider at each institution to help better understand the data. So how do you work with PCORNet? And you do not have to be a PCORNet institution to work with PCORNet. And that's exactly the same thing I'm going to be with the Trial Innovation Network. These are resources that are available to the broader community. So in PCORNet, we talk about an application to the PCORNet front door, which is at the coordinating center level. And there you can get some support for study design, certainly looking at eligible patients. The other thing that PCORNet can do is do a better job of describing what is usual care at your institution. At an institution, for example, okay, well, how many people are on drug A versus drug B? Or, what is the process for, the proposal we're putting in about postoperative delirium? Like, how much delirium is there within the system? And obviously, this connection to network collaborators, we can help with patient engagement if it's needed. Some teams are doing a fine job with that, and they really, don't need another group to take over in that area. So the step one, the requester submits a question. The coordinating center reviews the questions and consults with the requester about next step, converts the request into a query and sends it to the network partners. There's obviously a secure system that is being used to do this. And the network partners provide a response, which is sent back through the coordinating center to the requester. That's the general approach if it's just access to real world data that you're looking for. So here are just a couple of use cases that you can think about. Preventable is one of the big clinical trials that we're working on right now. And this is really the question about whether for patients over 75, is there advantages to being on a statin? So in this case, you're over 75, no CVD, you get randomized to either placebo or to atorvastatin 40, and the outcomes are really CVD events and deaths, cognition, and independence. And so the follow-up of the data uses Medicare data as well as phone surveys to assess cognition to help with the pretty much 100% approach to the outcomes because of the connection to the CMS claims file. And we just actually early this morning, we recruited our 100th patient at Johns Hopkins. And I think it's about 5,000 across the country. And I think, you can see this, it's got really good support from AARP, the Alzheimer's Association as well. And we think, and it does use a single IRB, which took a little while to get it going, but it is true that you can then have one amendment to the study protocol to respond to COVID-19 across multiple sites, and each individual IRB did not need to have a direct role in that. Adaptable is the other study that in the cardiovascular area that we completed a couple of years ago. And that was really the question about what aspirin dose offers the right balance of effectiveness and minimal risk of bleeding. So we went into the EMR, we found patients that had a known CVD event, and they were already taking aspirin. And we asked, would they be interested in joining a study to see whether 81 milligrams or 325 milligrams is better, because it was almost a 50-50 split when the study started. And we would identify a patient in the EMR. We would say, are you interested? They would go to a study website and be randomized with the consent process being done on the study website without an individual, that was the consent process. Again, knowing it was just the dose, and we were able to complete it. We had adapters, we had study partners that were with us the whole way. They looked at the study materials, they helped educate clinicians about the approach to this, and we got an answer that actually 81 milligrams, there was no difference in cardiovascular events between 81 and 325. So our recommendation was that 81 milligrams was a better dose, and that was published in the New England Journal a few years ago. This is another one. This is not a clinical trial, but actually it's a pretty interesting approach using the EMR data to look at blood pressure control across the 25 health systems that agreed to join into this. And it really looks at control, intensification of treatment, whether a patient was seen within 30 days after intensification of treatment. And you were able to see some important trends that, blood pressure control definitely went down during the COVID pandemic. And we haven't published it yet. I think it's under review, but, blood pressure control has improved in the last year, but it still remains less than what we saw in the pre-COVID area. And then these are being used, if you would, that same data to develop a cluster randomized control trial, a home trial to look at individual monitoring, but all based on really creating this single approach of how to assess process quality and blood pressure control across all the health systems. And once the data is in that common data model, you can apply this query to each organization and get an idea about where they stand. And so, again, this has been featured in several journal articles, and important, I think, to develop this learning health system around blood pressure control. And then finally, just to remind people, we all have heard about the difficulties with data on COVID hospitalizations, lab tests, in the midst of the pandemic. And, so the CDC did collaborate with us, and still do to some extent, to look at, to really have surveillance of COVID-19 activity across these multiple health systems. And you can see, they were able to look at racial and ethnic disparities in the use of monoclonal antibodies, understanding long COVID, myocarditis, and pericarditis rates after COVID-19 vaccination. So that is your sort of brief introduction to PCORnet. And these are, some of the places you can go to get started. It is a little complicated to understand exactly how to work. So if any of you want to start with, with the Johns Hopkins team, myself, or Harold Lehman, who knows the data well, and Megan Guave-Kern, who's been the program manager for the beginning, we can help you decide if what you wanted to do was with PCORNet would make sense. Okay, so now we're going to switch to engaging with the Trial Innovation Network. And I'll tell you a little bit more about this is NIH funded through the CTSA program. And we're going to talk a little bit about the network, resources and support, some of the ways it's been used, what's the submission process, and a few key takeaways. Just to remind you a little bit about the timeline, these things take a while to really get going. The CTSAs were first funded in 2006. Johns Hopkins received the funding in 2007 and then began partnering with UMB as part of the ICTR in the last 6 or 7 years. The Trial Innovation Network was launched in fall of 2016. It was refunded in September of 2023 for another 5 years. You see that first award was for 7 years. The second award is for 5 years. There's a little bit of change of who are the centers. And that's just, I think, what we have to accept with the grant making. It's a little bit competition. There's some turnover. Sometimes that doesn't make the stability of the network as good as it should be, but that's the reality. So the Trial Innovation Network, if you look at it, is to leverage the talent, expertise, and resources of the full CTSA program to act as a national laboratory to study, understand, and improve multi-site trials, and to inform healthcare by supporting successful multi-site trials to answer important questions. And all of this surrounding this concept of operational innovation, excellence, and collaboration, right? That we want to also be innovating at the same time that we are supporting these clinical trials. And this is the current structure of the Trial Innovation Network. You can see that NCATS funds this through the CTSA. Selena Wadi and Ken Wiley are the two leaders from NCATS right now. Just to make it clear, this is a cooperative agreement with NCATS. And so you see the trial innovation centers there are Vanderbilt and Johns Hopkins. And the RIC, which is the Recruitment Innovation Center, is also based at Vanderbilt. We clearly depend on all the CTSA hubs to support the network as well. Just to be upfront about it, some people think like, well, because Hopkins and Vanderbilt are there, it's only Hopkins and Vanderbilt studies that get supported. That isn't true. We are widely open to the community and support most people outside the community. And there is a process when you apply for support by which a committee that includes the NIH makes a determination about whether this trial is worthy of support. So it isn't Hopkins and Vanderbilt deciding by themselves. And this is really to remind you the CTSA network is really pretty impressive. It's 60 CTSA hubs, but as you know, like for example, 60 hubs would not necessarily understand that University of Maryland is part of it. So many of these hubs have additional health systems that are part of it. So you're really approaching about 100 of the biggest, most active research-oriented academic centers in the country. And we have various, if you look at these, the committees that we use to keep the Trial Innovation Network, one is the liaison team. So each CTSA has a liaison team contact, or we call the POC, the point of contact. We have monthly webinars with them to keep them involved. Each site also has a medical director that is somebody who's experienced in clinical trial that supports these. And then you see both, we talked a little bit about the innovation centers and the CTSA hubs themselves. And each one of the trial innovation centers has broadened beyond just their center to really take advantage of the broader capacity and expertise across the CTSA network. So you see each center now has a broader range of academic centers that they're working with to do their work. So the local liaison team is the front line of the Trial Innovation Network. Again, each CTSA program hub has its own official team. When you count the size of the teams, the multiple institutions, it is a little over 300 people. If you look at Johns Hopkins, ours is Liz Martinez is the liaison team point of contact. Steve Davis is really our direct contact, but that's broadening as well. So he hears us. I can tell you that Steve helped us with Mike Demansky support a large clinical trial using the resources as the leader of a study. And we frequently are contacting University of Maryland to say, hey, would you be interested in being a site in this trial? So every month there may be 3 or 4 studies that are advertised that are looking for sites. And we start, with ours at Hopkins, and then include University of Maryland for many of the same study invitations. So we really, and I have to say, it is the best consultation approach that I've been associated right now, because it's really taking the team where they are and saying, how can we help you? So you can say, I have everything all set up for my trial. I have my sites. I'm experienced as a DCC, CCC. The only thing I need help with is single IRB, or the only thing I need help with is recruitment. And then we fill that in. Or you can say, this is a person that has a really good idea. They think they have a funding source. They've never done a clinical trial. And they say, we need biostatistics support. We need the data coordinating center. We need the clinical coordinating center. We fill in the holes that are needed. And so the way this starts is there's a brief initial consultation that says, okay, tell me about the trial you're thinking about. Where are you? Do you, are you real early in the process, or do you have pretty much an application done? What resources are needed? And then we actually need to take that to the committee and say, this is promising enough that they can have a comprehensive consultation. The comprehensive consultation is a free service, and it is multiple hours of going through your process, helping you with the application. And then we may have a role in trial implementation. It depends on what you want. We may have a role in the recruitment innovation center that's built into the grant application. We may act as the DCC or the clinical coordinating center. It just depends on what's needed for you. And so these are just some of the things that we talk about in terms of the initial consultation. You see this innovations in clinical trial operations. We have some programs now that are looking to be more efficient for site activation. And we would love to work with teams to try to do that. We have some experience with using gamification approaches to provide feedback and a little bit of friendly competition to help sites get started and to help with recruitment. And we can use that in an easy way for yourself. We can help with single IRB coordination services. Some of the other that you see here as well, we do community engagement studios. If you need a national assessment of, with 10 or 20 patients and clinicians about, is this study going to work, and what's the best way forward? And again, more of if you look, the comprehensive consultation, we really are integrated partner. If we are written into the grant for a substantial role and ongoing, we obviously will spend even more time with you and make sure that the application is first rate in terms of protocol development and working on helping you apply. A lot of this, I have to say, is also strategizing on the funding source. NIH has become a pretty complicated organization. And sometimes we say we're going to start with NHLBI, but then we end up at NINDS. Or we may say, we think this is something that PCORI might be more interested in, and maybe not the NIH. So we do a lot of strategizing. Sometimes we deal with teams that have put the proposal in, gotten their feedback, and we help them fill in the holes so that they're ready to reapply and be successful. And this is on the trial implementation side. You can see that sometimes we can run the data safety monitoring board. We have biostatisticians that can help with that. Obviously, a lot of data management issues as well. And here are just some use cases of TIN consultations where you can see this first one was in pulmonary diseases. Really, they just wanted help with recruitment and retention plan and single IRB. We completed the consult. There was a funding decision not to fund it in 2022. Here's one, a phase 3, where we did community engagement studio, expression of interest, which is the process by which we help you find sites. We worked on recruitment material, and that went well, and the study is funded. Here's another one where it's in pediatrics. So you can see we really do go across the board in terms of different areas. We worked with single IRB, statistical support, recruitment and retention, and budget planning, and that is also been funded since this. And then this infectious disease one, where you can see where we really did a lot: data coordinating center, clinical coordinating center, and this was funded. We have done a pretty good job. I just kind of remind you, the HEAL, the pain studies that the NIH has funded in terms of the response to the opiate pandemic. And they gave us essentially the role of being the data and the clinical coordinating centers for those for the comparative effective studies around pain. We worked with 5 teams across the country. 5 out of 5 went from the UG3 to the UH3 phase, and NCAS has just told us that they want us to help with another couple studies. So that's a case where the team sort of came to us. They were pretty far along, but needed some support in terms of the actual conduct of the study. Again, we've talked a little bit. Let me talk to you about recruitment and retention strategies, the expression of interest process, and the single IRB. The Recruitment Innovation Center provides expert advice on recruitment and retention throughout the proposal development and implementation. Like I said, they can help with cohort assessments, eligibility of patients, what's going to make it easier, hard for you. what can we gain from community engagement, but that more broad definition of community? How can we help with recruitment materials? We have teams of patients that look at the recruitment materials. How do we improve the recruitment of diverse populations? A lot, if those of you that are trying to use social media, we have guides to that and experience with that. At Hopkins, we're very involved in sending out research invitations through Epic portal through MyChart. We have a lot of experience with that and can tell you what to expect in those areas. So those are, but there's no magic to recruitment, and it remains the biggest barrier to getting studies done on time. And we really need to continue to try to innovate in the area. I'm going to run through I'm just going to show you this because I know time is running a little short. This is the expression of interest process. So in this case, you come with a protocol. You say, we're looking for sites. We send out the description of the study to the 60 sites with a timeline for them to review. We have a budget review. They can do protocol reviews. One of the things that we're getting back from the sites that's really helpful from the team is can't find a PI, or this would not work at our institution because the experimental treatment is already standard of care. We get back sometimes not an interesting question. And that's good. That is really helpful feedback for the team as they put their final protocol together. And you can look at all this, after the presentation if you want to get more details on it. But you do see we have a tracking report access system that is really well built. So if I can go in as a Hopkins member and say, how many trials are we did we say we might participate in? Did we say no? What's the process? Has it been funded or not? And so who should apply for TIN resources? We think it's obviously investigators developing or leading multi-center clinical trials who could benefit from an expert consultation. We really like investigators that are interested in innovating with us. We know that it's such a large amount of work to put these proposals in that sometimes you don't want to be distracted, but that's what we do as the TIN. We take over the innovation and the evaluation of it. As you might expect, it always works better if we have more time. And you're talking, at least 60 days before a proposal is due. Obviously, soon, even earlier that is better. If you come to us with a last minute request, we will be very honest with you and say, we're not sure how helpful we can be, but we will try. You have 2 hours that you can get from us in the next 2 weeks. You tell us exactly what you want from those 2 hours, and we try to be as collegial and helpful as we can. And I think this is kind of a repeat of what we're trying to do. You can see those 60 to 180 days, depending on level of support needed, is what we think is going to make for the best relationship with the TIN. And you can go through this. It's a very much, you have to go through your local CTSA so they know. So if you want to apply, Steve Davis would have to know as the PI, write a letter of support. I would have to find second that letter of support. That it makes sure that you already are aware of any local resources that might be needed. And then it goes into our system, and I can just tell you, who was it? Yesterday I heard somebody that had a very good experience and said, we really do contact the PI within 48 hours of getting this to say, how can we help you? And you can see we are really building a lot of experience with 6 new proposals being coming to us in the last 30 days. But we have worked with 21 NIH institutes now with over 500 total proposals And you can see that about a third are comprehensive consultations, a third are just go to the initial consultation side, and you can see about 12% of the time we end up being a real partner with you in the implementation of the trial. And you can just look at this, a very broad number of therapeutic areas have been included in the 10 submissions. I do want to just mention to you quickly, we are developing some training programs that may be helpful to you that is going to be coming out in the spring. It's really geared for one of your professional program managers that may have experience doing single site studies and now are ready to move to multi-site studies. And we'd love to have a PI and a trial research manager work together on this. You can see some of the topics that we did with the needs assessment. I think you recognize the areas that people really want the most help with: accelerated site startup, managing sites, um, uh, single IRB, recruitment and retention, how do we improve diversity, electronic data capture, all of the things that are important. Pretty much, if you look at this, everybody thought every topic was important. And I do want to invite any of you to join our DIDAC symposium. This is where we bring people together from the biostatistical world, in particular, around innovations that may improve trial and efficiency. And you can see some are from Hopkins, some are from Vanderbilt. Kelly Kidwell does smart design, and she's at University of Michigan. We had our first one last month, and you'll be invited to others as it comes along. So let me just contact us. This is the way to help you get started. And in summary, I hope academic researchers do not abandon leading multi-center clinical trials. They are the largest impact. It's a lot of work. It's really, it's all years in the making. And I have to be honest, the frustration with NIH funding right now is pretty high, where, you really do need that championing at the NIH who's going to agree to these large, allocations of funding that's needed. And clearly, I think you should use resources to decrease the burden on study planning and contact. That may be the 10. It may be working with existing networks that StrokeNet, NeuroNet, Siren, all of these that are available for specific diseases. And sometimes they're easy to work with, and sometimes they're a little bit harder to work with because you got to go through their approval process and see how your project fits into their priorities. But once you get started in this and you have some support, well, it's a lot of time commitment. I think at the end of the day, these are the research projects that really define your career, and you feel like you've really made a difference when you get to the finish line. Thanks, and I'm happy to answer any questions.
Thanks, Dan. Wonderful presentation.
Thank you. We do have a question in the Q&A feature. And the question is, what are the steps for initial consultation? And is there an associated cost?
Right. So the steps for the initial consultation, if you go through that, you'll see you would say, I have an idea. You would ask Steve Davis as the CTSA PI at Maryland to just say, look, this is my protocol. This is why I need help. Steve writes I think this would be a good use of funds. I guess I'm not even sure myself if I would have to second it. It may be, I'm not sure, but it would not be a problem. And then it gets submitted, the initial consultation. You'll be asked in about 48 hours about what are the issues, who should we bring, and there is no cost for the initial, there is no cost for the comprehensive consultation. The NIH is funding us to provide this support. Again, where it gets a little bit where you have to be more negotiating is if we're going to have a role in the actual study and how that gets built into your study budgets.
I don't see any other questions.
Okay,
Okay.
good.
I think that everyone, unless there is a last minute question. Well, thank you for attending. And as I have noted in the chat, we will be emailing all the attendees a link to the presentation, the PowerPoint, and I believe we have the AI feature that has been recording. So we will have text as well to provide. And you can always email the ICTR Navigator, and I can put that in the chat as well if you have any other questions about ICTR resources. And with that, I don't see any others. Thank you,
Okay.
everyone.
Thanks, everybody. Bye-bye.
Bye.